Buenos días. Yo soy Mark Dangerfield y encantado de estar aquí en Bilbao para presentar y moderar al profesor Anthony Bateman. El profesor Anthony Bateman es psiquiatra y psicoterapeuta, es consultor del Centro Ana Freud de Londres sobre el modelo de tratamiento basado en la mentalización. Es profesor en University College London y profesor honorario de psicoterapia en la Universidad de Copenhague. Desarrolló, junto a Peter Fonagy, el modelo MBT, tratamiento basado en la mentalización, ya hace años, inicialmente para el trastorno límite de personalidad. Ha recibido premios como científico senior del British and Irish Group for the Study of Personality Disorder en 2012 y el premio anual Logros en el campo de los trastornos graves de personalidad, otorgado en Estados Unidos en el año 2015. Tiene muchísimas publicaciones, libros y artículos de investigación. Uno reciente, un libro de 2023, que es el Cambridge Guide to Mentalization-Based Treatment, que es una guía completa y muy práctica que ofrece una visión muy concisa del modelo MBT y su aplicación en diferentes situaciones y con distintos grupos de pacientes. También creo que vale la pena mencionar un artículo muy reciente del 2024, publicado en The Lancet Psychiatry, junto con Peter Fonagy y otros colegas, que es un trabajo sobre el tratamiento basado en la mentalización para el trastorno de la personalidad antisocial. Y es un ensayo clínico aleatorizado que evalúa la eficacia del modelo MBT y muestra precisamente la eficacia de este modelo con este perfil muy complejo de población. Bueno, el profesor Fonagy el profesor Bateman, Fonagy, pero Bateman, que está aquí. Sorry, I talked about Peter. Junto con Fonagy, Bateman lideran todo el modelo MBT y Bateman las formaciones en el modelo. También aprovecho para deciros que le tendremos en Barcelona en septiembre, la semana del 22 de septiembre, porque organizamos una formación en el modelo básico y también una formación del modelo avanzado, practitioner, para el modelo MBT para adultos. Todavía no ha salido, pero saldrá la semana que viene. Así que si alguien tiene interés, seréis muy bienvenidos. Pues sin más, Anthony, thank you so much for coming to Bilbao in what I know is a very busy period of time, also because next week there's another conference in Copenhagen. So thank you so much for being here.
Thank you very much. I'm speaking it, yeah. Thank you. Thank you very much for inviting me. And thank you, Elida, for being the person to invite me. We first met because I was role-playing, really, with Elida, and she was being the most problematic client that she could be, who she was actually seeing at the time. So I managed to persuade her not to be violent, I think, or not to commit crimes. Anyway. So I'm going to talk about mentalizing, what it is, and how to think mentalizing in general clinical practice. But I'm going to use two particular examples: antisocial personality, because that's been a current interest for a long time, but that goes across groups who, for example, are substance abusers or clients like that. I'm going to use them as an example of how to think mentalizing when you're seeing people who might show antisocial characteristics. But I'm also going to use the example of complex trauma as, again, something that you will meet with your clients very often, and how mentalizing might be able to be used in order to rethink your work with those clients. So really what we have to do with mentalizing is actually work out how much it's contributing to any individual's level of mental distress. That's the first thing we need to do. Whether we're working in social system, we're working in education, we're working in health. We need to work out their mentalizing capacities and whether that's creating a level of distress for them. We then need to really formulate those mentalizing difficulties that they may be having. And from there, we can begin to target their mentalizing just in our interactional processes, whatever else we're delivering with the client. So that's what I'm going to try to cover. So what is mentalizing? Well, fundamentally, it's the ability we have to reflect on our own mental states, our own inner workings of our mind, whilst at the same time reflecting on other people's minds. But when we do that, we also reflect on the interaction of the two. And it's our ability to be able to do that that tells us about actually what makes people behave or do what they do or say what they say. So it's really the understanding of ourselves in relation to others and the interaction of the two, which actually we understand from mental states. So we observe behaviors or people tell us they've done something, but we actually have to understand that according to what's happening in their mind. And this is what mentalizing is. It's a higher order mental processing system that integrates things about how we are and how we are in relation to other people and how the two are interacting. This is mentalizing does this. Okay, so that's what happens with your clients. Your clients, your patients, are unable very often to consider themselves very well, or at least accurately. So they may not know how they feel. You ask them how they feel, say, I don't know, and things like that. They're not very good at it. Okay, or you ask them, what was he thinking at that time? Said, how would I know? Ask him. And you think, oh, well, you know, did you have any sense of what he was saying, you know, where it was coming from, what was in his mind? I don't know. He shouldn't have done it. So they're quite difficult to work out these mind states of other people. And this is what mentalizing does for you. And when it works well, it provides a huge amount of social connection, of joining up with other people. And that's the key, I think. Now, how does it do that? Well, it develops over time from pre-birth, infancy, childhood through to adulthood. And mentalizing develops actually within the attachment and social system that the person is, as it were, in. So attachment processes, relational processes are incredibly important for the development of strong, effective mentalizing. So we know that, for example, that if your attachment patterns or attachment problems are insecure, they're disorganized, then actually it leads to unresolved states of mind, incapacities to manage one's own inner states, and so on. And there's a disruption then of all communication within the developmental system. And when that happens, independent of social economic factors, you get a disorganized system. And that creates disorganized mentalizing. Okay? So this means that mentalizing is really important in that mother-child system, in the actual care system, in any social system where you're trying to actually work with others. Because, in fact, a child, to learn about themselves, to learn about their own mental states, needs to be mentalized by someone and mentalized accurately to a large extent. So what we know about the origins of mentalizing, and this is important through development, through education, onwards through adolescence, is that actually sharing of emotions, being other organized as an infant is really important. But when you're other organized, you're trying to monitor and get other minds to respond to you. That mind needs to respond to you in a way that actually accurately understands your current need. Okay, so it needs to mentalize you, that mind, that person. So in fact, it's present very early on, and from about 9 months, minds start to align. There's a jointness if things are going well, where my mind is understood by your mind, and we can measure that to some extent from around 9 months. Now, eventually, by the age of 4 or something like that, actually, there's a sense of aligning with other minds. So it's quite quick that an infant child begins to realize this mind out there has got a life of its own. It's different. It can do things. It's agentive. Okay, I now need to persuade it things and things like that. Okay, this is quite an early on phenomenon where I now begin to realize that mind responds to my mind and so on. And by the age of 4, we can engage in group interaction and things like that if things are going well. But this process easily gets disrupted. But what you build during this process is a multi-layered system of complexity of mentalizing. Right? So in effect, I can have a sense I feel something. That's internal I. And we actually call that I mode. Right? I actually experience my own bodily state and it tells me my feeling state and so on. Right? But I feel nervous about something. So that's an added complexity. Now I give it context. So I simply build it. All right. And I feel this about that because of something and so on. So we keep building a level of complexity. And in doing so, we tend to read other people's minds and how those minds think about us. And then that joining of minds allows for effective interaction. Now, as you're going to hear, this goes wrong very often. And in those of you who are seeing people with antisocial tendencies, suicidal tendencies, disruptive behaviors, this process is going wrong. They're misreading themselves or they're misreading other people. That's what mentalizing actually causes. When it causes problems, that's what it does. So in fact, we've divided mentalizing in, to some extent, interactional terms for clinicians into the experience of the self, how I manage my own mind states. Can I identify them? Can I label them? Can I contextualize them? And so on. This is my I mode ability. Can I then bring that into the world and actually relate to someone and read their mind? I can understand their current state or ask them about it and so on, take an interest in their mind and so on. How good am I at that? How accurate am I at that? And when I've done that, I actually tend to personalize it. I tend to think, what is their mind in relation to what's in my mind? So I consider the interaction of the two. Okay, so that's what I do. Now, of course, if I'm overly sensitive, paranoid, I think you see me as shameful, say, or you see me as being bad or something like that. But actually, that might be me rather than you. So this is projective as well. Okay, so you don't think that. I don't read your mind very well. Then I've got me mode problems. I just don't read it. I simply actually assume it and things like this. So this is the interactional process. Now, but when it goes well, what we create is something between people. We engage in social connection. We join our peer group. So, for example, in adolescence, we manage to form a peer group. And that's a really important developmental process in adolescence, where we engage with people who we actually see as partly related to us, and we form a cohesive, functioning group of friends, if you like. Okay, and this is where we create something together, and this is called we mode phenomenon. We organize, so we create social connectedness. It's very important. All right. Now, as you're going to hear, of course, in antisocial, there isn't that sense of the social connectedness. That's what antisocial does. It socially disconnects and so on. All right. So along with that, we've defined just very briefly for you. So it's important clinically for you to work out, or wherever you're working, actually what ability has my individual to work on themselves, think about themselves, consider themselves, take responsibility about their own feeling states, their own context, their own understanding of themselves. How good are they? Okay, or do they find it impossible? How good are they at actually relating to others through reading others? In other words, are they empathic with others? Can they read other people's mental states and see things from other people's perspective or not? Okay, and when they can't, there's going to be quite a bit of trouble. But equally, if they do it too much, there could be quite a bit of trouble. We can actually, as it were, put down any sense of ourselves and actually spend all our time pleasing others or reading others and so on and things like that. So this can get out of balance. Okay? So when that happens, of course, you can't create effective we mode, the effective social connected involvement that means you feel you belong and can form strong relationships. But we also divided components of mentalizing into actual ability about self, about other, about cognitive understanding of things and being good or bad at that, about emotional understanding of things, being good or bad about that, about self or other, and so on. So it's divided up to some extent so clinically you can, as it were, measure it and look at it and think about it and see which areas are a problem with your clients. Okay? So I'm going to illustrate that a little bit for you. But the next thing I just want to mention is that MBT mentalizing work is quite simple in a way in its idea that whatever you see, whether it's suicidality, self-harm, drug use, anxiety, symptoms, and so on, it is a result of a breakdown in their mentalizing capacities. That's it. Okay, that's why you then assess their mentalizing capacities. Okay, you don't just go, well, you've got to stop cutting yourself. Okay, we've got to work out what happens in your mentalizing that leads to you cutting yourself and so on. Okay, that's what we need to do. All right. All right. So in a sense, the first thing I'm going to talk about then is mentalizing and actually around one's own self-experience and the ability to relate to others, because that is personality disorder. In personality disorder, we either have a problem relating to ourselves in some way, so we have an unstable sense of self. This is like borderline personality function. Or we actually have a problem with relating to others as well, which may go along with, of course, the unstable sense of self. But if I'm antisocial, I actually don't care about others. If I'm very narcissistic, I don't really care about others either. That's your problem. Okay? So, for example, if someone threatens you in your clinic or something like that, and you say, well, actually, this is difficult for me because I feel, a little bit anxious, that is this safe and so on, that's your problem. You say, well, but it's both our problems because I'm trying to think about you and I find it hard to think about you when I feel a little anxious and so on. Yeah, well, you'll have to stop being anxious then, won't you? You see, they don't care, so they dismiss the others. And when you look back, actually, they have strong dismissive lines of interaction and so on. So we need to assess these sort of areas, particularly if somebody has personality function dysfunction. And don't forget, personality disorder interferes with almost any treatment or intervention you're giving in whatever context you're giving it. Okay, and it's a much neglected area of thought generally, all right? But it will interfere with most things, okay? So let's have a look from this perspective at antisocial. Well, antisocial, actually, if you take it, they tend to think of themselves a lot. So they have a stable self generally. They generally think very highly of themselves, and it's other people who don't understand them. They don't join in with general social standards, so legal, ethical standards of social interaction. They actually dismiss those and so on. They tend to have shown conduct disorders during adolescence, so they're actually spending their time not linking with their peer group in the way that other individuals will, and they're deceitful to other people, they're irresponsible and so on. So they tend to tell lies and so on, and they can also become highly risk-taking. So they don't care about themselves sometimes as well, but they certainly don't care about you. So you can begin to redefine the antisocial function actually in mentalizing terms. So they've got self problems, they've got other problems. Other problems are me mode problems. They don't care about your mind. They're not interested in it. They're only interested in fuel for them, for their own mind. Okay, and that's a serious issue because they can't then join in with social interaction. And if we don't join in with social connectedness, we find it very hard to change. Developmentally, we learn and change and consider ourselves through being mentalized by someone else. Okay, so we technically really mostly learn by borrowing other people's minds. So we have to be socially connected. Babies are socially connected, children are, adults are. If we withdraw from that, we're stuck. So it's really important that actually you join them into a social network system. It's very important. Otherwise, change can't occur. And you can only do that if you're able to mentalize. So we can think about problems in antisocial function through these sort of I mode experience of themselves or through their lack of interest in others, for example. So in others, they fail to read others, they don't try, they don't read other people's emotion states, they're reduced interest in others, they've got rigid representation of others, you are this, I am this, and so on. And they tend to control and be coercive and push people to do things because that's their experience of how things are done and how they happen. So when you go to I mode, their own experience of themselves, they tend to be rather grand. Sorry. Didn't mean to do that at all. It jumped. There we are. They tend to be rather grand about themselves. They tend to show a certain level of self-esteem, which is strong in a way, and they tend to be rather narcissistic. So we've got real problems about their mentalizing themselves and mentalizing of others. But don't be tricked, because you will have a whole group of people who can be quite good at some aspects of these. Okay, so they're not just bad at them, they can be quite good. So for example, they can be good sometimes at recognizing others' mental states, but they're not empathic with others' mental states. In general, they're not good at others, but sometimes you have a group of people who are good at them. They're good cognitively. Once they're good cognitively at other mental states, but don't empathize effectively and care about that mental state, then they can exploit. Then they can commit fraud. Then they can actually manipulate and so on. So it's a very important process that they're engaging in, okay? And you'll find that with some of your patients. And that's actually in the literature where you can actually see that they're good at some of them at cognitive empathy. And this is in psychopathy, who are much better at cognitive empathy than they are emotional empathy. All right. So you get this groups of people who might be very good, but it's out of balance. Okay, and it's misused. But we also know that they're misread emotional states. Not only don't they care about them, they can misread them. And they have a general incapacity to read others' mental states, particularly their emotional states. They have an incapacity, so they then become even more dismissive of them. Okay. So what do we do with this? Well, what we do is actually in our general clinical work, but we did this with just MBT actually to organize it around treating people with antisocial functioning. In general clinical work, though, you need to assess these components of mentalizing much of your time, or at least think about them. And this is not that hard. Just think about how much that individual focuses on themselves, how they present themselves, how they think about themselves, what's their ability to differentiate between emotions in themselves, tense, relaxed, happy, sad, can they differentiate, or do they just have, I feel terrible, it's awful, everything's awful. There's no differentiation. So they've got an I mode difficulty. Okay? Get them to see, do they understand others? How often do they actually think they get this right, and so on, when they relate with other people? And people say, I know exactly what other people are thinking. That indicates an other mentalizing problem, because you never know exactly what people are thinking. But so they overstate their ability, or they understate it. They say, I have no idea. I don't understand other people at all. I don't know what they're like, and so on, and things like this. They've got a me mode difficulty. So you can pick these things up quite quickly. And they'll be then interfering with the relationships they have, whether it's with their peer group or with their family group or with others. So we define this for antisocial personality first off. And in order to do that, we, of course, actually have to decide how we're going to treat these difficulties. We're going to have to offer how to treat. So we divide it into phases. The first thing is actually the assessment, all right, with some education around relationships and mentalizing in relationships, which they all say they're great at. I'm great at that. I don't need that. And so I'm fine at it and so on and things like that. But we actually have to engage them. So we actually talk with them about that and we get them to reconsider themselves a little bit. But we then put them in a group, and we put them in a group of people like them, okay? Because they can't learn from me. They see me as rich, upper middle class, different from them, living in a different social world, not experiencing what they've experienced, being part of authority, being part of the system. So we tell them we are. So absolutely, I am. Thank goodness I'm not like you. This is terrible. This is awful, and so on. We can actually begin to talk to them, perfectly straightforwardly, authentically, and so on. It's very important in MBT. They have to experience there's someone there with a mind that they can read, and that mind tells them, basically accurate things, okay? And they will very often ask you things about yourself, and if they think that you're actually hiding, they won't come back to treatment. You have to be a person in front of them. So it's very important in MBT to be a person. But we get them to begin to rethink themselves, and then we actually get them in a group with others. Now, we also have in that group someone in our trial who's actually been treated, an antisocial person who's also had treatment. It's very important to reduce power differentials between us and them, and also have someone who they're more likely to listen to, okay, than us. Okay, so we have someone who's had treatment, and they talk to them about it and so on. And they actually were in many of the groups and so on. And then we focus that group very explicitly on their mentalizing difficulties, both between each other and actually within themselves. And we can, if necessary, give them some mentalizing exercises in the group and things like that. Okay, and we phase it so that we do all that for a time, and then we have an end point. So we have an end point where we're then looking forward to the future in their social connected system. How are they going to take their relationships forward in the future, and so on. So we structure the whole group. Now, there are problems in trying to do much of this, and many of the problems are actually in the clinician, because the clinician is actually anxious. And they're anxious because of maybe threat, worries about violence, and also that actually their own impact on them in trying to do the work is very problematic. So our clinicians were very worried about the patients not really engaging or dropping out or not really engaging appropriately and things like that. And they do try to engage clinicians and research clinicians in inappropriate interactions. So do be careful. You need to set up so that you have some level of protection and supervision with a team if you can. So, for example, they loved, if you look at our trial, which I'll come to now, of this treatment, they loved our research assistants. If you look at the trial, we have very little loss of data. Now, why do they love research assistants? Because they don't love clinicians that much. Well, they love research assistants because research assistants are usually about 20 to 25. They're more often female than male, and they're charming. Okay, so they love seeing them, but they try to engage them in inappropriate relationships and so on. So even that level, you have to have quite a level of protection, because they're very charming sometimes and things like that. So beware, because they will operate through a certain attachment processes where they set up relationships in particular forms, which have a level of control and power. So, so you have to protect against that to some level, all right? So we did a trial of this, and this is what Mark was referring to in terms of a paper in the Lancet Psychiatry 2025, it is just February 2025, are mentalizing for offending, this is aggression, violent males, okay? They were in the health system as well as the prison system. It was in a joint system, but they were in the health system. And what we found was that if you targeted their mentalizing, particularly about themselves and others, and their level of social disconnection, that actually their aggression, and you can see here, which was our primary outcome, where we are, aggression actually dropped significantly in the group that had mentalizing in their treatment program. They had lots of other treatment. They had anger management. They had other things in the control group. This is probation as usual. They were in the criminal justice health system, and their aggression actually drops relatively quickly and significantly more than if you don't target mentalizing. Okay, so it was a massively significant result. And you can see that in their community, there was major significant drops in violence. So they were relating differently within the community system because they were all in the community in treatment. Okay, so their violence dropped. Now, interestingly, the ability to negotiate conflict, okay, the ability of them to negotiate conflict, which is more domestic measure, i.e. domestic violence within their relationships, took longer to change. So their social violence, their social aggression dropped very quickly, significantly more if you target mentalizing. But it looks like you've got to learn to mentalize in more complex relational situations, like with your partner, if you're going to reduce your coercive and potentially domestic violence. So, but it does seem to increase your ability to negotiate conflict, but it takes about 12 months rather than 4 to 6 months. Okay, is what our data shows. Now, finally, just to mention, just in case you don't believe this, that we also looked at their mentalizing competence, because you would predict that if their mentalizing competence improved, that would actually mediate good outcomes. That would be the thing that's necessary to reduce the violence. And indeed it is, that actually those clients who improve their capacities in mentalizing, it predicts you being placed in the non-violent, the improved group. All right, so mentalizing is a mechanism of change. Right? Now that's important, because if you're dealing with groups of other people and you target their mentalizing, and it's a general mechanism of change, then you might expect focusing on mentalizing will effect change in whoever you're seeing, as long as it improves. All right. So all in all, it's a readily teachable sort of process. The clinicians in the groups were not all highly trained psychotherapists as such necessarily, but they were working with people with complex problems. Okay. So that led us on to a question about complex trauma, because all the people in the antisocial trial had incredible trauma backgrounds. Okay, so we became more interested in the effects of complex post-traumatic stress disorder as part of that antisocial system. So again, and this is just normal clinical practice, you take your client, your patient, and actually formulate the problems that they're showing, but in terms of their mentalizing capacities. You can do your formulation in whatever form you like, but it then has to have their mentalizing capacities in. So that's what we did. And we wrote a way of targeting the trauma experiences that they were still having. And we took the mentalizing definition of trauma, which is that actually in trauma, we're talking here about developmental trauma, about attachment trauma, about personal trauma, interpersonal trauma here, not necessarily the non-human agent single event trauma. This is developmental trauma. And developmental trauma is defined in mentalizing terms as the mind being unable to process an experience and unable to reach another mind to help them process that experience. In other words, the mind is alone. Because actually, when you have some experiences you can't manage or process, understand, contextualize, you actually seek another mind. You seek a partner. You seek actually a parent. You seek a caregiver. And that person mentalizes you to help you mentalize your unmentalized experience. All right? And if that doesn't happen, it's trauma. It lodges. It's not stored in the same way. Right? And it creates further symptoms. So the mind is alone because actually there's no longer a social referencing system. And what can I do when that happens? I can't join. I can't get another mind to help me with it. So actually, in the end, I actually drop out. Okay, I socially disconnect. And the core of trauma in mentalizing terms is social disconnection. It's the avoidance, mental avoidance, behavioral avoidance. Okay, and experience then of being alone and experiencing what's called trauma. So treatment therefore has to target mentalizing, and in targeting mentalizing, it has to actually create social connection, because we can only learn to change by using other minds. Okay, in essence, from a mentalizing perspective. So being mentalized restores personal mentalizing. Okay, and then I can process my trauma with someone. Okay, that's the key. All right, so we formulate with our patients their social disconnect and how they're attempting to socially reconnect and to what degree they're doing that. And in doing so, they very often have to, first of all, reconnect with their body, because trauma tends to lodge in the mind, rather like a abscess, as it were, and it's stored differently from normal memory and experience and so on. But also it creates a disconnect from bodily experience and so on. So the first thing we have to do is try to get a reconnection within the self to some degree. So we spend the first phase of treatment in mentalizing and trauma actually trying to reconnect the individual within themselves and actually help them with dissociation, for example, which is massive disconnect. So those clients that you've got who show complex trauma, the first thing to appraise is their self-experience. How disconnected is their self? To a large extent. How much dissociation occurs? When does it occur? How do you manage that? Because you can't process things unless you create a window of tolerance, a regulator of your anxiety. So we focus on that. And we then actually bring them into a group. But prior to bringing them into a group for mentalizing trauma, they actually have to establish both managing their own disconnect and dissociation, but they also have to come up with actually a understanding of what they might present about their own trauma experience to other people. So we rehearse that with them individually. So they have a series of individual sessions. So this is just someone who's had just triggered by imagining sexual encounters. And this is a real problem with her husband. And so he touches her in a certain way and she reacts and then can't engage with him at all. So it affects their relationship massively. So she is considering imagining that and being touched in a certain way, and that creates a sense for her of self-disgust and shame, and she then avoids and hides and withdraws. So she chooses that to begin to talk to the group about. All right, so we make a little narrative that is their own narrative. They have to own a piece of trauma narrative to bring to the group. We also formulate the trauma sort of cycle of problem where they actually lose their mentalizing capacities, because I said, once you lose your mentalizing capacities, that's when your trauma symptoms arise. You become super vigilant, you become highly anxious, so on. You have to avoid, and so on. All these problems that occur in complex post-traumatic stress disorder, and it dysregulates the self. Okay, so we have disturbance of self-organization at this particular point. So we actually try to formulate that with the client, and then they come into a group. And again, we actually organize the groups so that they are targeting the trauma, but not initially. So we have phases in the group, and this is very common, of course, and goes back to many, many decades to phasing treatments for trauma, where we organize it so we have the preliminary period of individual sessions where they'll have 6 to 9 meetings, and they know that they're then going to go into a trauma group, so they get some psychoeducation around trauma, around mentalizing, and trauma is the key, and actually about how trauma is affecting them, and then they create their narrative of their trauma that they're willing to present or talk to the group about. And in doing so, we actually then bring them into a group, but we don't ask them to talk about the trauma in the initial groups. They have 6 to 8 groups, 6 to 9 groups of actual getting to know each other. So we organize that and ask them to just tell each other about what they would like other people to know about them in the group. And MBT is very collaborative. So the clinicians themselves in MBT, in all MBT, also present themselves, what they would like the group to know about them. So it's actually horizontal. It's actually, there's not a power differential. This is really important in antisocial. As soon as they see a power system, they go for it and they're going to become more powerful. So it has to be as horizontal as possible, okay, to lower any power differential. But in this is done mostly by the sharing, what you need to know about me as a person, and so on, and my role. And we discuss it and discuss things together. We also define our values that we will follow. What sort of group are we going to be? How are we going to relate to each other? Are we a tolerant group of different perspectives? Do we accept different perspectives? Are we a respectful group? Are we a group who shares time reasonably? And so you start getting certain values of how we're going to work as a group, and we spend some time doing that. Don't talk about the trauma at all. After we've done that to some degree, we then actually go into the trauma processing phase. And in the trauma processing phase, we actually have to first decide on the order, because each person's going to get a group for them. Okay, so if there's 6 people in the group, which we have, then 6 people will be 6 weeks. So we have to decide an order. So what happens? Well, I'll tell you what happens. Okay, what happens is somebody volunteers immediately. I'll go first. Okay, they're the anxious ones who want to get it over and done with. Okay, and they're usually the ones you have to say, well, hold on a minute. Why don't we just wait a little to see what other people, what makes you want to go first, and so on. So we discuss it and so on. And then someone else says, I'll go last.
Please try again.
Siri, I think. Shut up, Siri. Okay. So each person gets to go, but in the end, we sometimes put names in a hat, and then we draw them out, and people quite like that. And then, because then you find very quickly when someone picks out the first name, they say, no, not me. Please, not me. And they say, well, all right, let's just see. And then you play around with the order, but having pulled them out of the hat, and that usually works. Now, we then actually organize that group. So you then have to come and present, and we have to get everybody to share the value that actually we're here for each other. So we have 6 weeks where you cannot be absent. No holiday. You can't go on holiday. You can't be ill. Okay, you can, of course, but you can't go on holiday. So everybody agrees we'll all be here, and we have full attendance. We get everyone to think about it, work it out. The only time we've had a problem was when a partner of one of the patients actually had wanted to be on holiday, booked a holiday, and she was torn about this. So we actually beamed her in on a laptop from Spain, actually it was, into London. So she was in Spain and beamed in. So she was there, and we agreed that in the group. So there's lots of ways of getting around it, but you want to try to make sure that they're all there for each other. And we then organize that presentation, in fact, but I won't It's organized from giving their story. And when they've given their story, we then move the group quietly so that they don't have to say anything, but listen to the others and how the others actually review their experience of the person who's presented. So if you presented, you then have to sit quietly, as it were, while we talk about, gosh, when I first saw you in the group, you seemed like this, but now I hear this, I can understand that. So you listen to other people, as it were, discussing things. And then after that, we actually discuss everything together. And meanwhile, you and the person who's presented, you, the clinician, the person who's presented their trauma, will make some notes. And then you review it in the last 10 minutes, and then they take that off. The following week, they will come back and discuss what they thought about it, what their experience was, if they've reflected on it, and so on, for the first 10 minutes. And then that group then takes on the patient number 2, and then we do the same thing again, okay? When we finish that, we actually have a review session, or potentially 2 review sessions. Did it work? What did we get from it? What was it like? And so on. And having done that, we do the whole thing again. So we do another 6. So each patient has 2. They love the second time. Okay, in all the qualitative pilot data, the first time they're anxious, it's a problem, they're not sure, and so on. It's difficult. The second time, they think it's much more useful. They're much more able to think about what they want to get from it and things like that. So it changes dramatically. From there, we actually have a phase where we don't talk about that anymore. We're now looking forward. So we're actually accepting where we are, what we've learned, what's happened, and we may have some grief about what we lost and what we didn't get because of the trauma that we experienced earlier in our lives and so on. But we're now looking at and reviewing our outside relationships and looking forward. All this that I'm telling you triggers and stimulates mentalizing. Mentalizing about self, learning about myself through the mind of the others, and creating social connection. And only if you can reconnect will you actually shift and change in our view. Okay? So that's really what we do. So in essence, I've just tried to illustrate the 2 major areas of problem. Think mentalizing. Think about how they're managing to do it around themselves. To what degree are they able to be secure, agentive, it's called, i.e. have direction and actually own that direction? How much do they understand their own mental states and the context of when those mental states are present and so on? Can they actually hold on to those mental states? You know, look, this is my value. This is my feeling at the moment. This is my idea and so on. How resilient is that? Or is it easily knocked off? Okay. How good are they at managing their me mode? How good are they and interested in others? Are they curious about other mental states? Are they able to listen to them? Can they empathize with them and so on? How much are they dismissive? How much don't they care? And things. They're quite easy to assess these levels of mentalizing function. Once you've done that, you can then work out how they go wrong and create the symptoms that they have. Right? So if I continually experience myself as shameful, disgusting, have a bodily experience of being sexually abused or trauma, which is unmentalized, then actually I'm likely to have that when it's triggered, see everyone seeing me like that. Okay, why wouldn't I avoid? It's too painful to be there and so on when it's triggered and so on. So you can assess this, but then you want to formulate it with your client, patient, and then you can start targeting. And that's really what MBT tries to do in an organized fashion. So think mentalizing. Is it contributing to the person's current distress, i.e. difficulties in their mentalizing capacity? Formulate that with them to some degree and actually then target the mentalizing so that you can increase their own personal narrative of themselves, which they can own, which is theirs. They're agentive at that point, and that will help them decrease their symptoms and actually feel more resilience as long as they can now socially reconnect, which is the overall aim. And that's why we organize some of these interventions now within a group setting in the community, rather than simply individual work. But you may require individual work in order to prepare people to then do something quite stressful, really, in the context of others. Okay, thanks very much. I'm going to leave some time in case there are any questions.
Well, thank you very much, Anthony. ¿Hay tiempo para preguntas?
Yeah. Yeah.
Shh, silencio, por
Question
favor.
over there.
Thanks for the dissertation. I have a question related to the antisocial personality disorder. In your experience, like
Can you put your
treating,
hand up? Where are you?
like improving their mentalizing skills in that kind of population leads necessarily to a better social functioning, like an increased empathy and all that traits. Because if not, I was thinking maybe that you're like helping improving their like manipulative skills, because like after the treatment they have like a better knowledge of how to predict others' reactions and thinkings, and it could be like, yeah, that like an improved manipulative like traits, right? And that's it. Thanks.
Yeah, I think I've understood. You're saying, could they become better mentalizers, but still not, but misuse that mentalizing? Yeah, so that you train them to be kind of more exploitative or to use people. Yeah, there's a side effect. Yes, we try to look at that by following people. And the study is over 2 years. So we didn't find that. But you're quite right that, but in general, I think what happens is, because let me start again. One thing, we train them to think about other people's mental states and in the group and to mentalize around them. What they find, I think, is that that gives them a better sense of joining in and being with people. And actually, that's a positive feedback phenomenon. So they don't misuse it that much, I think. We didn't find what has been found in other studies where they become cognitively much better recognizing mental states and then exploitative of the prison system, for example. Yes. Yeah. So we think it gives them enough positive affirmation to join in without exploiting. But good question. There's someone else. There's someone back there.
¿Más preguntas? Sí, aquí.
Yo también.
Sí, buenos días, muchas gracias por su presencia y por su conferencia. Yo le haría, bueno, creo que 2 o 3 preguntas. Una sería en lo que usted, cuando está hablando de mentalización y que la necesidad de que el usuario o paciente entienda lo que le pasa, o sea, pase a, digamos, al espacio psicológico. Quiero decir, me estaba acordándome sobre todo de Pierre Marty, en psicosomatista, en el que plantea que la mentalización es lo que, cuando no hay mentalización de un problema, es el cuerpo el que responde y se produce la patología somática. No sé si ha hecho alguna referencia, creo que sí, a ese respecto. Me gustaría, si igual, que pudiera usted comentar algo en ese sentido, de decir, porque estamos hablando de personalidades complejas y donde la mentalización, y sobre todo la mentalización de un trauma. Esa es la segunda pregunta que le diría, que le haría, sería, en un trastorno de personalidad como la psicopatía, como el trastorno disocial, el trauma, ¿cuál es el trauma que encuentran? Es decir, o situaciones traumáticas o dificultades en el desenvolvimiento social, como traumas, que se dan cuenta de que funcionan no adecuadamente o no funcionan que el no ajustarse a la norma en una serie de situaciones, pues le provoca una serie de problemas añadidos a nivel social. Si es un trauma genético o es un trauma sobre su forma de funcionar. Y la otro comentario que le diría o pregunta es, ha hablado en la parte que le he empezado a escuchar de clase social y trastorno antisocial, ¿no? Entonces yo, vamos, está usted hablando, está con personas, con pacientes que son de un área social determinada. Claro, el trastorno de personalidad, el trastorno antisocial lo podemos encontrar en gente con éxito social, millonarios, políticos, no digo, no menciono nombres, es decir, también una persona con un trastorno antisocial, teniendo este modelo, es decir, hay gente con éxito que funciona de una manera explícitamente antisocial, es decir, ¿desde dónde podemos intervenir? Porque ahí hablamos ya un poco del contexto social con los trastornos mentales, ¿no? En fin, muchísimas gracias y gracias por su presencia y por su amabilidad.
Yeah. All right. Thank you. Your first question, the body responds. Yeah, if there's no representational level of experience, then the body responds, and that is an excellent point. And when mentalizing is ineffective or not functioning very well, and then the body does respond. So it responds, as it were, through violence or through something, or you do something to the body, and so on. So representing inner experience is incredibly important for mentalizing process. And that's why in trauma, we spend some time getting them to try to reconnect with the body. Otherwise, the body is continually dissociating or experiencing things which are painful in various ways. So that's right. I think your second question was also related to the trauma backgrounds and so on. They tend to be violent, they tend to be coercive and punishing, and they're usually physical. So they experience huge amounts, and again, this is in the epidemiology literature, but it's in our study as well, that they experienced massive devaluing as a child, if you like, and it was done through coercion and punishment and so on. And they were shown that the way to change things or things got done was also through coercive interaction. So let me give you a quick example because it's a very severe one. A man who was then in our study, who was 25, his father was a enforcer for a drug gang. And as an enforcer, he took the child, who was then 6 onwards, in his enforcement meetings to train him as an enforcer. So by the time he was 12, this child was able to break people's kneecaps and things and stuff like that without creating hospital damage and things like that. So he was just following this around, and it was only that he came into treatment thinking there was something really wrong when actually he felt he wanted to do that to his first child, and he thought this was just horrific, and he came to actually be seen. He'd been arrested lots of times for various things, but it was that sort of background that was very common in the antisocial interactive aggression and violence. And your final point is I don't know the answer to, so I left it to last. But in general, antisocial behavior, you're quite right, is not necessarily related to just lower social context in many ways, but it is, remember, highly adaptive generally for you as an individual, whatever form it takes. So I don't know how you actually get people who are in the more socially adapted antisocial narcissistic role position to actually come for treatment because they actually deny there's any problem and so on. So I can't help there with some of your politicians, I'm afraid. I only wish I could. So I'm sorry about that.
Tiempo para una última pregunta.
Here, I will try to make, good morning in the first place. I will try to make my point in English, but I'm not super confident about it. I would like to ask you if you have theorized about how specific scenarios can create impairments in mentalizing at a group level. Because we are talking here about mentalizing in an individual level, but you know, I cannot stop thinking about what is going on Gaza, and we are allowing it to continue. So what's going on at a group level? Some impairment of mentalizing.
Sorry, is this sorry, I missed the first part. Is this in a team or a group of? Oh, I see. When it goes off in a group altogether. So in other words, the group's slightly out of control in mentalizing terms. Yeah.
A difficulty in mentalizing, but at a group level.
Yeah.
And I'm including us.
So everybody's not mentalizing. Yes. Well, that happens a lot. Okay. In antisocial, I got some video, but I can't show it you here. But you know when it's going off because patients stand up. And I've got groups with everybody standing up, including me. We've all got up. We say, no, I think we better sit down. And, you know, and everyone says, I'm not sitting down. No, he shouldn't say that. You know, no. You actually, in a way, you stop the group. You say, you have agree time out of non-mentalizing groups. Okay. So at the beginning of an antisocial group setting up the structure, you actually agree that, look, if everything starts to go wrong, we're all going to agree, we sit down and we actually have time out, all of us. Okay? But yeah, you have a value that will actually allow you to do that somehow. Okay?
Bueno, thank you very much, Anthony. Muchas gracias a todos.